have a look at the esophagus here. So you have in front of us, quite a thickened fold. If you look at the image and you start at the 9 o'clock, you can see at the 9 o'clock and at the maybe 10, 11 o'clock normal gastric folds, top of gastric folds, also at the 6 o'clock, and then at the 3 o'clock or 4 o'clock, like quite a thickened fold, gastric mucosa extending up into the esophagus over about 1 centimeter, and a little bit of that having crept under the squamous mucosa, maybe from previous information, some squamous mucosa has grown over the top. So this is, I guess, Barrett's esophagus, has been biopsied as such. Let's talk through the features of why this might be a little bit concerning. So actually the first feature is the mass effect that this fold has. So if you really insufflate, and the patient's losing gas a bit, so maybe we can just have a little bit of pressure to get it to distend. It's often the case with patients with Barrett's. Then you see, even despite, it's okay now, maximum distension, we have some mass effect on this. You can also even appreciate, I think, in white light, that this pattern is not completely regular up into the 3 o'clock position, where it creeps under the squamous mucosa, or maybe more correctly, the squamous mucosa creeps over the top of the Barrett's mucosa. Using this imaging platform, so here we have a 760 series or 700 series 760Z Fujifilm gastroscope. We can really nicely see that, but of course there are some tricks. So if you are interested in imaging, then we can turn on virtual chrome endoscopy, in this case BLI. And if we again, distend and get a freeze, you can beautifully see that change in the pattern just towards the middle of this area. And then if we go up closer, we can use a little bit of extra zoom and use the cap to stabilize to image areas where potentially we've lost that structure. I think we should use some acetic acid maybe to just bring this out. So as a person who's not sure in this situation, what are the steps? So if you are doing this gastroscopy and you see this, of course, main step, biopsy it. Very important. Biopsy it, and the biopsy result here showed high-grade dysplasia. So that's important because a biopsy alone in this situation is probably completely sufficient, plus some photographs, maybe a video if you can, and bring it to your multidisciplinary meeting. However, if you have an interest and you want to detect more subtle areas of dysplasia, then you can apply acetic acid to the surface of the esophagus, and you better clear it quickly because it's pretty irritant to the airways. This patient is intubated as we're about to perform a therapeutic procedure, so not much of an issue here, but in your situation maybe there is. So we just flush it down the channel and get it to hit the area of concern, and then also we can close the lumen a bit to get everything to come onto the acetic acid, suction up. I have done that really already, as much as you can of the acid, and then wait. And so you've got about 20 seconds of time. In the meantime, you can really nicely assess the pit pattern, because now we have chromoendoscopy. It's very nicely seen here. Probably the area of concern is actually at the 6 o'clock, here where it's already losing the white effect. So loss of acetal whitening or going red 20 to 40 seconds after application. The live image is at the bottom right, but I'll unfreeze it because maybe you can't see it. And so you see that the overall thing is remaining white. But then we have this area underneath which has immediately lost the acetal whitening. And if we zoom on that, this is probably the area of concern. So what do you have in this image, even in white light? But with chromoendoscopy, you see crowding of the glands here. And almost certainly in the center of this, there is high-grade dysplasia, or maybe even early cancer. And if we go to BLI, or blue light imaging, we will have a better understanding of how, if we zoom out a little bit, how the glands up here are crowding together. Maybe this is dysplasia, low-grade dysplasia, and then we get into the central area where it's not so easy anymore to see that pattern, and maybe this is an area of early cancer even, or certainly high-grade dysplasia. And when we're looking very close, we can also add water. I don't know what setting our water jet's on, so I want to check. It's on maximum. Don't have your water jet on maximum if you're doing lesion assessment. because you will destroy what you're trying to assess. And that's maybe still a little bit too little. But look how you can combine, maybe a little bit more, yeah. You can combine, wait a minute, while we just suction this out. Of course, your patient has to have some sort of airway protection. Yeah, a bit more maybe. So already the extra magnification comes in very useful of the water. I'm just going to take some air out so we can see. This is how you handle the water if you want to get an image. You need to have a cap on, you need to suction out the water. And then here, maybe go faster with the water because we need to get a little bit more.
Is too much air.
Yeah, maybe. Go more water. Yeah. So sometimes in the dependent position it's fine, but in the non-dependent position it can be more difficult. Make sure you have airway protection if you're doing this kind of thing. And we can try just to really get out now. We have that beautiful image we're looking for. So look at that. The combination of the two can give you a super beautiful image of that, probably early cancer in Barrett's esophagus. And look how subtle that is. So if we zoom right back out, again, you can still nicely see the overview and why like that is so subtle and could easily be missed if you think back to the original image that we had when we started, and if you're just pulling out without seeing that, then you might miss it. The clue here, I think, is the mass effect that this has on the esophagus. So yeah, I hope that's interesting. That's how subtle it can be, and that's how much there is a possibility to miss early cancer if you're not looking a lot, if your patient's not sedated properly, if you're not using a cap to look at Barrett's esophagus, if you're not using a high definition instrument, and if you're not having these patients on dedicated lists with someone who's interested in Barrett's surveillance. All right. Thank you so much for watching.